Hello, everyone. Thank you for joining this evening. I don't know why I always say it like that. Like, hello, everyone.
You sound good.
uh, we're gonna give it just a few minutes here before we get started. Let everyone get a little bit more time to get signed in. All of you that are here, welcome. Know that your camera is off and you are muted, and that is how it is supposed to be. We'll talk about how to ask questions and things like that here shortly. But just hang tight for just a moment, and we'll get started here and just give it a couple more minutes.
Frank, you leave your camera on, buddy. You got a beautiful scene behind you. The
Yeah, he
tree,
does.
the color, no audio.
He's muted.
Yeah, it's pretty out there as well. Was that the San Francisco? What's that? What bridge is that? The Golden Gate?
Golden Gate Bridge, man, just for you.
Beautiful. Beautiful.
I see
Yeah,
some
it's a
familiar
beautiful day in
names.
San Diego, everyone. So hard to complain. It is.
Dr. Erickson, hello. Dr. Um,
Oh, you see Tammy Belichick's here. I haven't seen her in
Dr.
a long, long
Belichick,
time.
Dr. Randall Smith, Dr. Robbins, a lot of familiar names. Dr. Lawrence Hummel. Yeah, a lot of familiar names. Welcome, everyone. Dr. Diaz. Oh, yeah. Hello.
Hello.
Oh, Dr.
From
Diaz.
Peru.
I know. Oh my God.
Wonderful. Is that your Dr. Chen that just signed in that you're going to see tomorrow? Or is that a different Dr. Chen?
I think it's the one from
Yi
tomorrow.
Hong Chen? Wonderful. Wow, we have Peru, we have Malaysia. Welcome everyone.
She
We
actually
have
is in China
Indiana.
right now, I think, on her way back from China to Malaysia.
Okay. For all of you that are curious about Mayor's
Ah,
whereabouts, he is heading to Malaysia tomorrow to speak there, which part of my intro talks about you speaking internationally. So
ah.
close, that's tomorrow.
Yeah. Not looking forward to the flight, but besides that, I'm excited.
How long will that be?
That's 15 hours to Seoul and then another 3.5 hours to
Ooh,
Kuala Lumpur.
wow.
Will you be napping on the plane?
Oh, definitely. Definitely napping.
You get bored, give me a call. I'll be
Actually, I'll be flying over you because we're gonna go West Coast.
I'll wave at you.
Excellent. All righty. Well, let's give it just about one more minute. We'll start at five after.
You waved at us. I should have done this.
Um, again, for everyone joining us, your camera is off and you are muted. Throughout the webinar, you will have the ability to ask questions and raise your hand, and I can unmute you. Um, we'll get started here.
You want to hear something funny while we get started?
So
Sure.
I went like that to wave to Mayor, and there is a couple people walking by. They wave back at me. It's hilarious. Well, that's cool.
well, people are nice in San Diego, it seems like.
Yeah.
Sunny weather, good mood.
They didn't put me off. That's a plus.
They must be from Indiana.
Super friendly. Yes, they're visiting.
Okay. All right, everyone. So thank you for joining our webinar this evening. Welcome. We do these webinars monthly. So if there's ever any topics you want us to discuss, always feel free to put them in the chat or reply back to the recording email, and we're happy to take those into consideration as we plan our schedule out for the rest of this year. Our topic today is stop guessing and how to diagnose and treat sleep apnea versus TMD cases. This is going to be an interview style discussion with Dr. Patel, so feel free to utilize the question and answer box at the bottom of the screen or raise your hand and I can unmute you so that you can ask questions in addition to the questions that I will be interviewing Dr. Patel for today. Frank, did you have anything to say before we got started?
Yes, Trish. First off, thank you for jumping in for me. I appreciate you very much. As always, Dr. Patel, it's such a blessing to work with you. Thank you again for all the support. you provide to us, and for the wonderful knowledge that you share with all of our attendees and everyone. Thank you for spending some time from your busy schedules and your days to just be a part of this. We are truly blessed. It's been 26 years. We keep doing this, and we just continue to grow. We have some wonderful people that surround us, and thank you all.
No,
And
thank you,
thanks.
Frank.
I'll step back.
Wonderful. Yes, thank you all for joining us. Now I'd like to introduce our dear friend here, a dear friend of mine, a dear friend of True Functions, our clinical director, Dr. Mayoor Patel. Now, bear with me. He's got a huge bio, and that's why we love him.
Oh my goodness. We can shorten that.
Dr. Patel received his dental degree from the University of Tennessee in 1994. After graduation, he completed a one-year residency in advanced education in general dentistry. In 2011, he completed his master's in science from Tufts University in the area of craniofacial pain and dental sleep medicine. Dr. Patel has earned his fellowship in the American Academy of Orofacial Pain, the American Academy of Craniofacial Pain, the International College of Craniomandibular Orthopedics, the Academy of General Dentistry, and the Pierre Fauchard Academy. He also has earned his diplomat in the American Board of Dental Sleep Medicine, the American Board of Orofacial Pain, the American Board of Craniofacial Pain, and the American Board of Craniofacial Dental Sleep Medicine. Presently, Dr. Patel is a co-founder of the British Academy of Dental Sleep Medicine and the Ben Pat Institute. He also serves on the American Academy of Craniofacial Pain as secretary, board member of the British Society of Dental Sleep Medicine, and a board member and an examining chair for the American Board of Craniofacial Pain and the Craniofacial Dental Sleep Medicine. In the past, he served as founding and board members for the Georgia Association of Sleep Professionals. Since 2003, Dr. Patel has limited his practice to the treatment of TMJ disorders, headaches, orofacial pain, and sleep apnea. Additional contributions have been published a textbook for dental sleep medicine and numerous chapters on orofacial pain and dental sleep medicine, consumer books, one on treatment options for sleep apnea and the other on understanding temporomandibular disorders, and various professional and consumer articles. Dr. Patel speaks nationally and internationally on topics of dental sleep medicine, orofacial pain, and TMJ disorders. So thank you for joining us this evening. We're so thankful to have you always. And we'll get started here.
Well, thank you, Tricia. But Frank, yes, Dr. Chen just says hello from China to you via text. And she invites everybody here to come to Malaysia and learn. The people are amazing. The food's a whole nother story. But, something to consider in the future. Write that trip off.
Yeah, sounds like a good plan. Let's all go to Malaysia. Wonderful. Alrighty. So let's get started. When a patient presents with both sleep and TMD symptoms, what is your first clinical priority and why?
Yes, that's a great question. So, and this happens a lot, I suppose, and it happens to every one of us. I'll give you some stories, I'll tell you why, but in the early days, when you start learning about sleep, you really go on the bandwagon that everything has to be sleep related. And the problem is you got to listen to your patients because frankly, they came in because of pain. So when I look at this, when I see or suspect that they, of course, have a sleep component, pain is what got them through the door. I'd probably keep them in the back of my head as far as what to do for them, but my priority is to always address their chief complaints. In my early years of doing this, you want to educate these patients, and you do it well, and you do it from the standpoint of what you really feel that they need, but you lose them, unfortunately, and you lose them because it's just too overwhelming. So priority, I think, would be chief complaint. If the chief complaint coming with sleep, then work with the sleep angle, even though there's an underlying TMD issue that you might identify, just factor that into your care. What I primarily would see is a lot of pain patients. Then I'm going to prioritize pain first, but in the back of my head, I'll take into consideration suspected sleep-related issues that needs to be further evaluated or assessed. But I don't want to overwhelm them, and I think that's the way to properly approach them. So typically, take the history, go with primary chief complaints. Focus is the chief complaint first, and then take it from there.
Alrighty, great answer. Again, feel free to use that question and answer box if you want me to ask any of your questions too.
Tricia, am I getting graded?
Say that again?
Is this an open book test? Am I getting graded here?
Yes,
Okay,
100%. Yeah, you got an A on the first one.
And if you don't mind, Tricia, if anybody wants to chime in and add comments, please do. Because I mean, this
Yeah.
is really an interview process. We're just talking. There's no right or wrong answer. If you feel that, hey, this would work in your hands, then it'll be great that everybody, has an opportunity of hearing it.
Mhm. Yeah, raise your hand and I can unmute you, like I said, or you can use the question and answer box. Where do you think most clinicians get it wrong when trying to differentiate between sleep and TMD cases?
Now, this is my opinion. All right. So I just want you to be mindful of what I'm trying to say. And I'm not trying to like call anybody out here. But I think if you can hear me out for a second, a lot of times where we get it wrong is when we just want to fit in one camp. So if we're in the sleep camp, then everything we do is sleep related, which there is a time and place for it as well. And I think also if you're in the pain camp, then the only thing you're really focused on is pain related things. Sadly enough, the two is not separable. The two, there's so much overlap. So where we get it wrong is where we just stay in one kind of mindset. And the intention is always good. And of course, the outcomes is to make people better. But you then miss these patients. And the problem you run into is when there's an underlying jaw-related issue that never gets addressed. The sleep aspect may be what your primary focus in, and things go bad. Or the opposite may be true, where you might have a person that has significant pain, but some of the pain may be induced by improper sleep, sleep fragmentation, and all the other things that sleep does as far as modulating pain. And then you get frustrated because the pain approach is not working. So, where we get it wrong is where we try and stay in one lane. I think this is an area of space you got to be in both lanes. You could prioritize your approach, but you got to respect each other from the standpoint that pain and sleep is pretty much inseparable.
Sure. I always hear that once you see one, you can't not see the other. Like it's just so interchangeable. I
And I
hear
mean, I think,
clinicians tell me that all the time. Or like once they see one, they can't not see the other one.
yeah, like I think this is Jameson Spencer. I'm gonna quote him directly. He's like, sleep is easy if you understand the joint. I mean,
Yeah,
quite straightforward. If you understand the joint, treating patients in sleep is not a difficult thing to do.
sure. Dr. Erickson asked, what percentage of sleep patients also have treatable TMD disorder?
Oh gosh, what percentage of sleep patients also have a treatment? Pretty much, you could treat every sleep patient with this. I mean, Sorry, you can treat every sleep patient as a TMD component with a sleep approach. Because if you think about treating TMD in some of these patients, it's all about giving them vertical, in some cases, some form of protrusion, right? So if you look at the literature as far as what's the incidence of a TMD situation in a sleep patient, it's roughly about 50%, depending whose work you read. So just say that every sleep patient, at least half of them have some underlying TMD component. However, the treatment can overlap quite similarly, but if you can just understand what you kind of going in with, then the question might just be how aggressive do you go with your bite? Do you do some adjunctive therapy prior to maybe putting them in sleep appliance? And this will be more of your clinical pathway and your rationale as far as how to address these patients. But yeah, no, great question, Alan.
Do you want to expand on that a little bit? One of my questions for you was if once you do identify an overlap, how do you decide what to treat first versus what to manage secondarily?
Yes. Okay. Yeah. So I think that will fall right back onto primary chief complaints, right? So if the chief complaints pain, I'm going to go on the pain angle. Now, I don't know if I'm going to sideswipe from your questions, Trisha, but if I do, then we'll somehow blend it in.
You're okay.
The thing we got to look at is, if you look at just the literature for just a second and you look at some of the publication by Smith and his group, when they looked at patients at Johns Hopkins that came in to a pain clinic presenting with classic TMD disorders, they opted to put these patients in a sleep lab and using polysomnogram, the better way of actually identifying probably a sleep breathing disorder and other sleep issues. They found that almost 48% of them had two other sleep related issues, sleep breathing disorders being one and insomnia being the other. Then I want to quote another paper out of Brazil. And what these guys did is they had a series of patients that came in that complained primarily of having sleep apnea as a diagnosis. However, they were coming in to get an oral appliance. In that group, those researchers found that almost half of them had myofascial pain or myalgia as a component of a workup diagnosis, right? So we now may need to ask the question, what might just be the common thread between the two? And I know we've done a webinar with True Function in the past about connecting the dots, maybe about a year or two ago, which they probably have
Hmm.
access to. And we looked and we journeyed through the literature, and the common thread, besides sleep fragmentation, amplification of pain, all these things that happen because of bad sleep, is parafunction, frankly, bruxism. So now, if we understand that for a minute and we go from the standpoint that we have a patient in a chair and we try to prioritize which way to go, I'll take pain first. Because if I can get them out of pain and they feel better, they're more receptive to hear me out and maybe go down a different path as far as assessing other etiological reasons that may contribute to it. One might just be sleep, right? But that being said, also, and this is where appliances come into play, the lab is a great resource because you could use some appliances to manage the TMD component that indirectly would probably improve the airway or at least not make the airway worse. Right? So there again, the lab has a big component here as well when it comes to how do we maybe approach these pain patients with if we're going to consider appliance therapy and also not make the airway worse and if anything make the airway better. So I mean there are many ways to approach this. I think as we go on through tonight's discussion, I'll bring up some of the pearls, but I want you to understand that I would probably prioritize pain first over sleep.
Perfect. And then what specific clinical indicators tell you that this is primarily a sleep case, primarily a TMD case, or both?
Yeah, so that there again, what you'll find is like your questionnaires will be probably the entry point, right? So you might do an Epworth
Mhm.
questionnaire, you might do a stop bang, you might do a Berlin questionnaire to kind of just get an idea of, well, how likely is it this person may have a sleep breathing disorder. Of course, the symptoms they present, they'll talk about being fatigued, they may talk about them snoring. Of course, fatigue is not just sleep related, there's many reasons why they could be fatigued. But then if you dig a little deeper and you look intraorally, you might see like a high Malapati score, which we know is associated with the high risk of apnea. You might see like a vaulted or craniofacial underdevelopment, other subtle signs to try to give you the inclination that maybe there's an airway component here as well. So, I mean, it'll probably be more the history taking, your intro findings will be the two things that will raise your suspicion that they may have a sleep breathing disorder of some sort. And the key here is a suspicion until proven otherwise, right? So the only way we know for sure is a sleep study. And that is necessary to be able to get an appropriate diagnosis to therefore then manage an underlying sleep aspect if they do have one.
Mhm. Perfect. Yeah, and we'll get to the actual treatment part and the devices. I know we have a couple of questions about those in just a moment. Can you discuss the causal relationship of sleep apnea, bruxism, and TMD? Does sleep apnea cause bruxism, leading to a cascade of TMD symptoms eventually?
Alan, if I gave you this answer today, then you would not go back and watch the webinar, which is about 45 minutes long, that had amazing literature associated with it. But I'll give you the Cliff Notes version. So it's a great question as well. The problem here is we can't say that bruxism, let me rephrase, you can't say that every sleep apneic patient bruxes. Because there again, when you look at the literature, only about 48 to 50% of patients that have apnea show bruxism as a component of it. So we don't have a good causal relationship. There may be some association between the two entities. So we've got to be very careful with that. But the fact that we see that there's at least a good number of these patients that do parafunction and it may be associated with the airway, we could probably take that. But we don't know until we get them tested, right? Then the causation of TMD. We know TMD is multifactorial. There's a psychosocial aspect that we really need to take in consideration as well. Especially in today's world, I can't tell you how many patients the last 3 weeks I've had come in where they were stable, doing well, but they came back in because of one thing, and anxiety kicked in. And the reason why is a few of these patients unfortunately came in because they lost their jobs. And these are young kids out of school, about 5 to maybe 8 years, and the majority came in upset. The reason they lost their job is the jobs are now taken over by AI. So the firms did not need them. And this was the accounting sector, there's a financial sector, and so forth. So we know that there's many reasons why TMD could be a rise besides airway, right? We know that stress, anxiety, other factors as well, trauma, and
Mhm.
so forth. So it's not just one thing. And I never want you guys to hang your hat. There's only one thing why people have. And you also respect the fact that these patients may have multiple etiological factors that have now just kind of come to a head, making them symptomatic. So, you got to, unfortunately, we got to look at the big picture, and it's not always easy at times, but we got to go with an open mind that there's a lot of reasons for it. But Alan, I would encourage you to maybe see the old webinar that was recorded at True Function, where we actually literally journey the literature as of a year ago, because I'm sure the literature has changed and I've not kept up in the last year. But I mean, I keep on revising what I say as new and new data come out.
And if any of you want a copy to that webinar, you can email me at Trisha, Trisha, at truefunction.com, and I can get you a copy of that. I'm happy to share that recording.
So Anju's got a direct question.
Yes, you
Yes.
said Andrew? Yeah.
Yeah, Anju does. Right. So how do you
Yeah,
manage
I was gonna say that
people?
was exactly. I want to talk about starting positions and treatment and all of that. So
Okay, well, you go first, and if I can loop her a question in, I definitely will. If not, I'll
yeah,
answer it separately.
yep, yep. Um, okay, so we'll start with the next question is, and this might late into the Invisalign question. So, how do you determine starting position in these cases, especially when balancing airway and joint stability?
Yeah. Oh man. I didn't know I had to like study for this. I should have studied for this.
Sorry, I should have given you a heads
Okay, so
up. Yeah.
Sounds like a
so
future webinar.
look at Frank. Great
Mayor knows all
question.
the answers, so
No, no, no,
we're
no,
just putting
no.
him on
And
the
I'm going to
spot.
be wrong. And please, anybody's welcome to correct me. I like to be corrected because there again, there's just so much out there. So Tricia brings up a good question. How do you manage position? Is that what your question is?
Yeah, starting position in these cases, especially when balancing the airway and the joint.
Okay, so I'll give you two stories here, and they kind of will align with each other. The first, for those of you that know Brendan Stack, the late Brendan Stack in Vienna,
Mhm.
Washington, he was an orthodontist. He did a lot of TMD treatments, a lot of amazing cases. There's a lot of good stuff that he's actually contributed to the field. But he used to always say to me, when patients don't get better, give them vertical. And at first, I'm like, man, this does not make sense. Give them more vertical. And I mean, the more you think about it over time, the more it kind of makes sense. And in your clinical practice setting, the only way you're going to really learn some of these principles is to put them into play. And if you think about what he's trying to say, is when you give someone more vertical, what you're actually doing, if we just go back to just basic muscle physiology, muscles only do two things. You either contract or you actually relax. And we talk about the elevator muscle specifically. So for an elevator muscle to relax, the more the mouth is propped open, the better the person's going to feel because you're actually forcing the muscle to be in a state of relaxation. Now, we also have to be practical that we can't have them open, or you're not going to get a lip seal, they're not going to be compliant, and all the other variables that come with it. But there's a degree of opening one should consider. And then I'm going to fast forward many years later. I was not proud of this moment, but we had a course in Atlanta, and there's a group of us that went out to the bar, and we all were getting happy and drinking alcohol and all that good stuff. And one of the guys said, I don't get it. I don't get it why people with orthotics get better. And I was like, man, we spend so much time talking about how splints, there's a time and place for it and how it helps. And I did one thing to him, and it became a light bulb moment. I took my hands and I said, all you're doing with the mandible is you're doing down and forward. You go down and forward with the mandible, people get better. Now, if you think about that one for a minute, the down, which means vertical, but the forward is protrusion. Now, if you think about what protrusion ultimately does, it takes the tongue forward as well. Well, if you take the tongue forward as well, you indirectly going to affect the airway. So when it comes to bite position, what I'm looking to do, depending on what we are talking about here, if it's for TMD splints as an example, I'm going to give them more vertical. But I will keep a component which prevents the mandible from falling back. And the reason for that is, once again, if we go through the literature and you look at the effects of vertical on airway, the one I like to cite is the one that has these graphical pictures that talk about what happens to the velopharynx with vertical, and shows that 80% of the time you actually have a reduction in airway space. And then the other 20% of the time, nothing happens, or in some cases, you might improve it. But in that same subset of research, what they showed is if you took the mandible and slightly protruded it and then gave them vertical, the airway stayed open. Okay, so my thinking then is if I'm going to use appliances, and if I need to use an appliance, I'm going to use something that probably has some vertical component to the merit of from a musculoskeletal standpoint, but also a component that prevents the mandible from slightly falling back. Therefore, I'm not going to make the airway any worse. If anything, it's going to be where it's at, or I might actually improve it. All right, so when I'm taking a bite, I'm taking these two things into consideration. when it comes to appliances.
Perfect. Yeah, that makes sense. Um, when and where do you see appliance selection go wrong? And how much does that design actually impact those outcomes?
Uh, so if
And
I
then I
take
want to
a,
get to the Invisalign question
yeah, no,
for
no,
Dr.
fair,
Haley.
fair, fair. What I think happens when I get calls from people from True Function, for instance, that have used
Yeah,
an appliance and then, things don't go the way they needed to go, and we talk about it. At times, what it comes down to possibly is probably appliance selection from the standpoint bulkiness, right? When you have bulky appliances in instances where you have very little tongue space, it then might mean that you need to protrude the mandible more to offset that difference to try and get good outcomes. But if these patients have pre-existing jaw issues that never got addressed, and now you significantly start protruding the jaw, the chief complaint I'll get from these dentists is my patients are now hurting. They weren't hurting when I examined them. I put a device in at 3 or 4 weeks in. Now they're having discomfort. So I think where people get wrong is falling on the notion that one appliance might be better than the other, which some manufacturers claim. And I think you got to be very careful with that. What I would say is find appliances that are very sleek, slim, and from a patient standpoint, easy for them to use. It's pointless having an amazing device appliance if it's difficult for a patient to seat it, advance it, or whatever needs to be done with it. So where people probably fail is not picking the right appliance from the standpoint of how much volume it's going to occupy, and maybe the inability for a patient to be accustomed to using it, or in some cases be accustomed to even titrating the device if you are allowing them to do the titrations.
sure.
So I will say this, in my early years, I do remember, and I wish I had published this or did something with it. Years ago, I would get two different appliances with the same bite from two different labs, and I'd have these patients wear it. And we'll do ambulatory studies and just look at what one would do or what the other would do. And this is so anecdotal. Once again, it wasn't a very well done study, but the observation was interesting. I found that a thicker appliance, if I used one, I could still get the same outcome, but I do protrude those mandibles a little bit more than the other. The ones are much more slimmer. So I'm not going to talk about which appliance is which. I mean, True Function has an array of appliances. If anything, use their resources. But the point I'm making is we got to be mindful if these patients already have large tongues, constricted maxillas, small space for the tongue to sit in, then why are we taking clunky appliances to try and offset that? But with
Mm.
newer materials that Frank actually uses, the appliances that I use from Frank's lab, you don't have to worry about the thickness or the bulkiness that is associated with it.
Yeah, I have those talks every day with clinicians. Every day they're calling saying, I want to know details on, where, how much space, how much vertical, all of those components. So that's a daily conversation that we're having for sure. So how would you manage the TMD orthotics if a patient is in Invisalign?
And now, if they need to have TMD orthotics, we're making some assumptions here. Say they have intolerant arrangement. Say there's something that an appliance is necessary. Then you're going to abandon Invisalign. You got to abandon therapy, get the jaw working first, be asymptomatic for at least 3 months, and then possibly return back to Invisalign. There's no way to dual manage it. You're going to have to bail on one.
Like a temporary device or something like that where you can reseat it every tray doesn't work?
So now it depends what we're talking about, right? So if it's myalgia, for example, and maybe they're now clamping or clenching on these Invisalign retainers, and as a response to it, it's causing some form of myalgia. Things I've done, I've used like a temporary appliance over an Invisalign, and to your point, reline it every so often. Or sometimes I'll do Botox while they're going through Invisalign. So we control the amount of force they generate, and then they can go ahead and complete the Invisalign. And once it's completed, then transition them into an authority to maybe control parafunction if that's what the reason is for it.
Great question. I get that one a lot. Um, if a TMD condition is asymptomatic, but there are signs like deflection, deviation, limited range of motion, how does this influence your client's design and treatment approach?
So the key to that question here, if they are asymptomatic, which is fine, there's really nothing we're treating, right? Signs such as deflection, deviation would mean something. So a deflection, of course, would mean that they have a disc displacement that's non-reducing. I'm not sure if you're familiar with this, but they now call this, oh my God, there's a new term for it. deviation without return to midline, I think, or something along those lines. We don't use the word deflection anymore. And deviation is
Hmm.
deviating to return to midline, something like that. Don't quote me. It's the new
Okay.
terms that they are using to describe this. But to that point, with deflection deviation, if they're asymptomatic, and the thing with limited range of motion is going to be important because if they are limited with protrusion, there's no point doing a sleep appliance for them, right? If it's sleep that we are talking about, because for you to get good outcomes, you got to be able to protrude. Now, would I take a Hail Mary and try it and see would it make a difference? Maybe. But what I might do in that instance, I might do a temporary sleep appliance and see by me protruding them to the point that they can tolerate, do I make a significant impact in the airway before I transition them to a custom device? So those will be my limitations. And there are patients I've turned away that can't protrude for whatever reason, no symptoms of any sort. They don't want to do any active therapy. They don't see a reason for it, which you can't really justify it if they don't have pain. Then it's okay. You monitor them. A few, we would try trial appliances. They were not successful. Back to CPAP. And a few surprised me that even if I could take them to maximum protrusion and keep them in the temporary device, as long as they were asymptomatic and a validation study showed that there was improvement, we've transitioned them into a custom-made oral appliance. But I would take that into consideration because you need protrusion when it comes to sleep-related therapy, right? Otherwise, it's pointless.
Sure. I think we could do a whole webinar on our next session. So really high level. Can you walk us through a case from diagnosis to final outcome?
Oh gosh, yeah. But Swamnya, thank you very much.
Deviation with
Thank
and
you.
without correction.
That's right. The new term is deviation with a correction, which means they come back to midline, or deviation without correction, which basically is the old term of deflection.
Yeah.
Thank you. Ah, that's got to stick.
We're actually getting a couple more device questions in, so let's answer those while we're on that
Okay,
topic.
go ahead.
Is there a combination appliance for controlling clenching like an anterior programmer does at the same time as improving the airway snoring, like a true sleep
Yeah.
device, true dorsal appliance?
Yeah. So any sleep appliance that's modifiable where you can have the lab add a discluding element. So it'll be what like an anterior program is, a little button in the front, typically on the maxillary arch, and therefore you disclude the posteriors, and you can also manage the airway simultaneously. So you take any sleep appliance of your liking and ask the lab to add a discluding element to it that will then take care of both those two issues that you're describing.
Again, we'll open up from where your bite is, we'll open it up a little bit. So just keep that in mind when you're taking your bite.
Great question. And actually, so to your point, I'm glad you bring that up. You have to factor that in. If you're going to add a discluding element, there's going to be a thickness of the appliance and then whatever vertical you need to clear it. And if you don't give the lab that, the lab will contact you and ask for permission to increase the vertical or ask you to send a new bite in. So to try and minimize all this, do what you think you need to do chair side. See how much vertical you're going to have at the back. See what type of device you can use so you know how much how acrylic thickness is necessary. And then capture it exactly how you want it to be. And then send that to the lab. But thanks,
Mhm.
Trisha, because that does happen a lot with
Yeah.
me as
Uh,
well. We're
Dr.
undersure.
Patel,
And any of, oh, go ahead,
Yes,
Frank.
Frank.
if I can chime in on that, just as Dr. Patel was alluding to, consider the impact on the patient, because once we added this gluting element, you're adding, 3 to 4 millimeters of vertical. So if you have lip seal, concerns, tight lips, tight cheeks, or anything like that, those are things to consider when you're requesting, a discluding
Yeah, absolutely. Um, what is your favorite temporary mandibular advancement device?
My tab.
Really?
Yeah.
All right.
EMA now every now and then, but
Mhm.
I will use probably a MyTap. Now, if I know I'm going to finish these patients off in an EMA, hypothetically speaking, then I'll pair the temporary device to what I think my end device is going to be, because I hate to jump between one and the other. Why I like the MyTap is you don't need straps, right? So they don't need bands to adjust. You just turn that dial and you move the jaw forward. So yeah, I mean, I have both, but if I had to like go to one, I probably would jump on a my tab.
Good to know. Good to know. Don't ever go searching for a a video on how to seat the MyTap with him,
Oh,
okay?
Do search for the video because the superstar that's on the other end of receiving the MyTap is to your left, depending on how your screen's set up.
We're superstars on the MyTab videos. Okay.
I forgot about that.
Oh gosh, I did not. Okay. So let's actually answer a different question, then we'll go back to the one I had asked you earlier. So Dr. Smith had asked, he said, I'm doing more TMD in pain and I'm getting more cases that are unusual. How do you approach young kids like 12 to 14 that are presenting with joint pain? What is your approach with these young kids?
Yeah, so young kids are interesting, right? So with young kids, the first thing I'm worried about if it's joint pain is it any idiopathic condyle resorption or is it even autoimmune at that age bracket? So I want to make sure I get good imaging, rule out that the joints are healthy from that perspective. Now, say it's just a hot joint. A lot of times with children, I find that one of the biggest triggers is some form of injury. A lot of times sports injury or something that happened to them. So most of this is acute. In that instance, I might just go off with a temporary orthotic if there's an indication for it. I sometimes will use an aqualizer in kids. Every now and then I may use a quick splint, but I might just do a round of anti-inflammatories or things of that sort just to try and put the fire out. Now let's just go one step further and make some assumptions here where I need to use an orthotic on a kid for a period of time. I'd do it, but I make sure that I try and get them out of it within 2 to 3 months. I don't want to keep a 12 to 14 to maybe a 16, 17-year-old in an orthotic long term. I'll use it as a short term, acute resolution of the symptoms and then bail them out of it. All right. So kids, it's not the intention of keeping them in this orthotic because I want them still to grow. And nor do I want to make any significant impact on any possible occlusal changes at that point in time.
Perfect. What do you do if the joint clicking occurs in the bite chain in the what do you do if the joint clicking occurs and bite does change post sleep appliance?
Yeah, no, this is where it gets interesting. The first thing you got to ask the question is, and this is something when we talk about it, and here's a pro. Every patient, regardless of what they walk in for, if they're going to get some form of a device, always ask one important question. Was there ever a previous history of a clicking popping joint? And document that. And the reason for that logic is if they had a clicking popping joint, say 15 years ago, by the time they present to your office today, their range of motion may look completely normal. There's no deflection or there's no deviation without correction. There's no limited range of motion. Laterals look good, protrusive look good, everything looks good. Then you stick a device in the mouth and now clicking happens, right? So that's one scenario. Or the other scenario is they had a chronically anterior displaced disc. A device gets fitted at some point down this timeline, they have a unilateral posterior open bite. Now, when you wear a sleep appliance, it's always a bilateral posterior open bite because when the pterygoids contract, the mandible comes forward, both sides actually have a change in bite. In this situation, you run into is when it's unilateral posterior open bite. I'm thinking you've actually reduced a disc. Now you just have to deal with the consequences of not documenting the pre-existing condition they have, and this is where it gets tricky. So to try and avoid these uncomfortable conversation with your patients, if they say, yes, I had a history of a clicking joint in the past, then I'm going to plan and lay out everything that's going to go wrong if the device is doing what it needs to do and some of the consequences that may arise, such as a clicking joint may return. And I explain to them why it's returning, what they had, why it stopped, why everything looks normal, what may happen when they wear it, one being clicking now returns, or two, the disc actually reduces, which I've done you a favor, frankly, uh, frankly, um, God. Anyway, I did you a favor, and as a result of it, we've got this change in bite. But if they know going in, they're okay with it. And we've had, unfortunately, instances where this does happen. But the good thing is documented. So as long as it's documented and this conversation has to come up in discussion, you can at least bring up the informed consent, which I sometimes will handwrite. Patient states that they had a past history of clicking popping. Outcomes were discussed, such as a return of a clicking joint. Two, bite change occurring on one side, the side where the clicking was previously reported. And then I had them sign that. So we are at least all on the same page when this happens. Right, so that's what
Consent,
I do. I'm
consent,
sorry.
consent.
Yeah, consent, consent,
From
consent.
my previous life, consent, consent.
Yes.
The big thing. It'll save you in a lot of scenarios. Back to the kids. Had a teenager that developed jaw pain while in ortho. Orthodontist referred the patient to our office to try to help get rid of her pain. What would you do in this case?
So Rob, that's a hard question to answer. Forgive me. I'm just going to make a lot of assumptions here because that's how I'm going to be able to answer this. The question is, what's the diagnosis, right? So what exactly is the reason for their pain is where we would start. If it was due to, say, they're wearing elastics, and as a result of wearing elastics, they develop some form of capsulitis, right? In that case, we abandon the elastics. I may disclude them a short period of time using either aqualizer. It'll be very hard to make like a quick splint if they have brackets in, as an example, and do some NSAIDs. It all depends on what the original diagnosis is. If it's myalgia that happened, once again, moist compressed, soft diet, maybe depending how old they are, maybe muscle relaxants. I may be topical muscle relaxants that you can get a compound pharmacy to compound. And this is just to deal with the acute onset because they were fine, and at some point orthodontic something happened. So your approach is going to be for treating something that's acute, which means it should be completely reversible if you're able to identify what went wrong.
Perfect. The next question, I actually get this quite a bit. It's funny, different like philosophies of treatment. Uh, when you uh, when you see an anterior open bite develop from a patient
Yeah,
wearing an anterior, have you seen an anterior open bite?
yes. It
With an
does
anterior
happen.
deprogrammer?
Yeah, it does happen, unfortunately. So with the anterior program is because the point of contact is over the centrals, lower centrals, or lower laterals, or depending how big the pad is. And if you have these aggressive clenches, you will see some form of intrusion that actually takes place, and that does lead to an anterior open bite. So this was one of the dilemmas I ran into early in my years, and I would be gun shy to use antidepressants. But there again, if I used a flat plane splint in these patients, the symptoms got worse. But if I took all the posterior teeth out of contact, the symptoms got better, which meant there's no way I'm gonna get away with a flat plane splint. So this is where the invention, if I might use this phrase, or the advent of this thing called a mirror appliance came about. Okay, and mirror is basically an anterior deprogrammer glorified. It's got a flat upper tray, but the lower has two buttons or protrusions that are over the canines. So there's no force on the centrals or laterals. It's all on the longer, broader teeth, such as your cuspids. And with those, I've not seen, if any yet, anterior open bites. And those that had anterior open bites, I would discontinue usage of the deprogrammer. And over a period of time, it actually does close back. And then I would transition them into a mirror appliance. And I'm now following those patients without seeing any changes from occurring. So it can happen. I mean, there's risks with anything we do, but you want to try and see if you can mitigate it. And one way to try and mitigate is to use a different type of approach, same principle, but it's called a mirror appliance fabricated at
Mm-hmm.
True Function.
That's your function, yeah. And I often see clinicians will order like a slider with their deprogrammer, just so there's something in that posing to protect the lower teeth. The great thing about the mirror is it is two arches, so that kind of mitigates that issue too.
I
Like,
mean, if I want to add to that, some of these patients will say, I want to make sure my teeth don't move, right? Because they had ortho or they were Invisalign prior and so forth. And this is true. So they're already wearing a lower Essex, and you're going to use an appliance on the upper. But if you use a mirror, since it's made out of the PMMA puck, it's very nice, dense, and tight, which is like a rigid retainer, which is better than the Essex retainer, in addition to having those two little bumps placed on the canines to give you that disclusion.
yeah, perfect. Yeah. Um, I've seen a number of patients lately with facial asymmetries. The condyle is shorter on one side. Can this have to do with losing the disc at a young age? If a child develops a displaced disc, will it affect growth?
Yes, it can happen with that, Alan. So this is where you take a history. Probably there's some trauma as a kid. You may have had idiopathic condyle resorption that happened as a child at a childhood age. We also have to be mindful that this could be just purely growth and development, where you have hypoplasia that took place, whether it be the condyle or the ramens or a combination of both. So it's very hard to really know which caused which. If there's a history of them having, say, some injury as a child during the time period of critical growth, then maybe we could lean more towards hypoplastic development of the mandible. If it was later, there was loss of a disc, and now you see resorption or degenerative changes of the condyle, you will definitely have a significant asymmetry, which you definitely see in arthritic patients, where if a joint's melting away, the chin has a tendency of shifting in the direction of the joint that's dissolving.
What are early warning signs that a case may fail? And what do you do differently when you see that?
Early warning signs. So early warning signs to me would be stuff like, all right, so if I take a pain patient, for instance, and they're not getting better, then I missed something, right? Or vice versa, if I have a sleep patient and now the symptoms are getting worse, or there's no progressive improvement with their sleep, these will be my warning signs that something's wrong. Either I missed something or something was overlooked. Um, or I didn't take a proper history. And this will happen on occasion. So,
Mhm.
when you see 100 patients and 85 of them give you a good outcome with the approach that you've been taught, with the methodology that you use, and then you get a 15 that look like the other 85, but yet the outcome's not going the way they should, now I need to question, what did I miss? And the key here is probably your diagnosis. Some things may look the same, but the etiological pathway may not be the same. So therefore, what you might think is myogenic pain may be something totally different that needs to be looked at. And I make mistakes to this day as well. I mean, I'll go with the mindset that I believe this is what you have. I'll start treating you for this condition and they don't get better. And I just got to pump the brakes. There's no point dragging this out. That's the other thing in dentistry. We think that miracles will happen if I just drag this thing out to 6 months. You know, within 4 to 6 weeks, if I'm not getting some response or some tipping of the needle, then I've missed something. So this is the point where you just pump the brakes, start from scratch, reassess, maybe get some lab values done if you think now there's some systemic reason for this, and then revisit what I missed and then approach it. So
Perfect.
when
Yeah,
things don't go the way you expect is what my clues would be.
perfect. What have you changed in your workflow to make treating these cases more predictable and repeatable over time?
Yeah, so predictable. I would think that I would probably say that I would, okay. My biggest change probably was implementing or using orthotics if I needed to use orthotics where I was not going to violate the airway. Okay, because
Mm.
prior I would not, I would know that it's a problem. I would say I'll come back to it kind of a thing. And then when patients get better, they don't come back to follow up and have the airway assessed and so forth. So I now try and lean more towards devices where I manage the airway, not to the point of trying to improve it, but prevent it from getting worse. So I'll give you examples. I will use a lot of times off-label sleep appliances as TMD appliances. Okay, because I know it's not going to let the mandible fall back. Okay, but if I need to titrate this device at some point, because now they got a diagnosis for apnea, I don't have to get them into another device, right? In other words, I don't want to like tell them they got to pay twice for the same treatment. So if I know going in that airway is going to be a factor, and I suspicion with my high suspicion that they're going to have an airway problem, I may put them in what was talked about earlier, a sleep appliance with a discluding element if I'm concerned about their clenching, and just hold them at that bite. Not even significant protruder. It could just be even edge to edge or just a habitual bite where they may be at. Give them some vertical and just hold them there. When the testing comes back and it says, oh, you have a problem now, and airway is a factor, now that same device can now be titrated to now open up the airway. Right. So I think what I'm doing now a lot more is if I think airway is a big predictable outcome that's going to be found when the testing is done, then the appliance I select is an appliance that I know I can then use as a sleep device if need be. And if not, it'll maintain itself as a night guard.
Perfect. Um, for a patient with deviation who is using oral appliance for OSA, if the patient has myalgia towards the side of the deviation, is it okay to do an uneven protrusion? For example, can the following be done using a 28 strap on the right side and 27 strap on the left side where the deviation is?
Yeah, no, for sure. Sometimes just turning the joint in the opposite direction by changing strap sizes, or if it's a herps, maybe advancing one side more than the other, or any combination
Sure,
of sort. Yeah, totally fine.
sure, perfect. Um, again, back to that question that we skipped over a little earlier, high level. Can you give us kind of a walkthrough from diagnosis to final outcome of how you do the diagnosis
Okay.
to
Yeah,
treatment to the device? I
no,
know
for
that's a
sure.
very big loaded question. I
No, and
can see
I'll
your
pace.
wheels turning.
No, it's
I
fine.
can
It's
see it
fine.
in your face.
I know. I'm thinking. I'm gonna blow some steam here. So the way I'm going to answer this question is I'll just go through, and some of the things I'm going to piecemeal from what I already said. Maybe just kind of put it together for you. So we're going to make an assumption. Let's just go with the assumption because there's too many ways of looking at this question. Let's just say the patient came into the practice, and primarily 90% of the people that walk into my practice have pain, right? So here they're in the chair. We go through a sleep questionnaire, we do our intro exam, and the back of my mind flagged, yes, there's an airway component. Maybe they express that they snore. Maybe they express that there's witnessed apnea. So these are definite outcomes where if I get you tested, you're going to test positive. So that's the back of my mind. But they have some level of capsulitis that's going on here. Let's just say they even have myalgia, because those two kind of go hand in hand at times. So now my approach is, what am I going to do for you? Right? So if I suspect that this is playing a role, my primary concern will be, let's put you in some anti-inflammatories. If I see a reason for some muscle relaxants, let's do that. Let's put you in authority to control parafunction. That is what we suspect is the reason for why they are where they are. But now, knowing that I need to get them tested, I'm not going to throw that, hey, you need to go get a sleep study done. I might drop a couple comments and say, listen, these are things I'm seeing. I think we need to come back and revisit this, but let me get you out of pain first, and then we can have this formal discussion about it. Fine. Now, this is where I make that decision. If I know going in that sleep is going to be a variable, I may ask the lab to give me an EMA with a disclosing element, right? So an EMA gets fabricated, comes in, I deliver it. I may or may not put the strap. Because if I put the strap on it, it's going to act like a Ferraro appliance. If I take the strap off, then it's going to be like an antidepressant. So if I want to hold the jaw forward, I'll put a 21 strap and just leave it at that and not give them any more from that point forward. I'll monitor this patient for 3 to 4 weeks. At that point, if things go better, where they're actually improving, now I'll bring up that discussion about those other symptoms I saw or the intro findings that suggested they have an airway problem. And say, all right, if it's okay with you, I'm going to make a referral and get you tested to see if you have an underlying sleep issue that may contribute to the big picture. Now, at this point, I don't get pushback. And the reason I don't get too much pushback at this point, because what they came in for has improved, or it's better by now, right? So they're actually now listening to you. They're all ears. And this is where the referral gets made. Now, when the referral gets made, I make it clear that the night that they do the study, I don't want the appliance in the mouth. So some of the physicians I use, they do multiple nights. So I'm like, all right, the 2 to 3 nights you're doing, you're not wearing this device you have. I want to see how bad your airway is without me influencing it. Because if they step with this appliance, and this is where the physician and I kind of have a little rebuttal, I'll give you our two sides to it. The physician says that, listen, if they're wearing this thing every night, then we should test them with that every night, right? To see, is it impacting the airway? And my argument is, yeah, that's fair. Maybe it's making the airway, maybe it's controlling the airway as long as the device is in. And the study comes back and the AHR is less than 5 and we're all happy. But the patient gets better and they discontinue wearing the device as they move on down their journey. But now if I tested them without, maybe it shows they actually have apnea. So this is where we have this conflicting, which way do we go? So I tell my patients, I don't care what the physician says to you, but I want you to take the device out. Give me a study with nothing to influence the airway. Study comes back. If I get a positive diagnosis, which there again, if they say they have witnessed apnea, snoring, and they have all these things that you already suspect they have, you know it's going to be positive. At this point, what is happening is they're wearing a device, right? So 3 to 4 weeks have gone in, maybe another 2 weeks has gone in by the time they get a consult done, maybe another week thereafter, a study gets done, and then maybe a week thereafter, the results are reviewed. So we're talking about 8 or 9 weeks down this road from the time they came into your office. But at some point, they've been wearing your device, which means the myalgia component, the capsules may have improved. So now I feel comfortable. If they test positive, let's protrude. Let's now protrude that mandible and now deal with the airway, right? So indirectly, the pain's taken care of, and while the pain's being taken care of, a diagnosis is rendered. So now I can go ahead and therefore initiate the sleep aspect. Let's take scenario number 2. A patient already has a diagnosis of apnea, presents themselves to the office. Fine. So they have apnea, they've got pain. Well, I know I'm going to treat the apnea because they are here. We've had a conversation. They don't want to wear CPAP or they tried CPAP, all the things that you and I hear about. But with these patients, once again, I will get their pain under control with the orthotic. And once it's under control, then and only then protrude the mandible. Now, I've done it the other way where they've had pain, but they have significant desaturations, and I'm a little worried about it. So I'm like, all right, we're going to go and advance it. And it goes both ways. Sometimes nothing happens. Patients get better both in sleep and pain. But a lot of times, the pain gets a little worse. So I'm a little gun shy. So what I will do is control the pain first. And once they show that there's adequate control, then I'll go ahead and start protruding the mandible forward. Right? No right or wrong way. It's whatever works in your hands, but that's basically how I take a look at these patients.
Perfect. Wonderful. I think that was a great way to kind of end our webinar today, bringing it full circle of everything you've talked about and then, kind of going through those cases. So thank you so much for this evening. We'll hang tight for just a couple more minutes. So if you have any last minute lingering questions, feel free to drop them in the question box. Otherwise, I think we'll end it there this evening. Any questions? All right. Well, while you're thinking about it, thank you again for spending your evening with us. We really appreciate you, as always, taking the time to spend with us this evening. We will be sending out the recording of the webinar to the email that you registered for. So look out for that. We also will be hosting another webinar next month. So keep an eye out on our education page on our website where you can register for our next month's webinar. And in the meantime, if there's anything we can support you with regarding your MIRAs or your deprogrammers or just guidance in general, don't hesitate to reach out to us at the lab, or you can email me at trisha@truefunction.com. And we look forward to seeing you again on a webinar here really soon.
All right, guys. Well, thank you very much. I appreciate you all.
Thank you. Thank you, Mayoor. We appreciate you.
You're welcome. Take care, guys.
Safe travels.
Thank you.
Yeah. Bye, everyone. Have a good evening.